We need to make it work here in India. We have to figure out the cost model that will make it work. The one thing I would say is when you see the videos that Dr. Payne showed, that was, more or less a start-to-stop hysterectomy. And those were big fibroids, and you saw the efficiency of those hysterectomies. That was fast. And if you can back-to-back do surgeries with that kind of efficiency, and your OR time comes down, I'm sure you'll see that the issue of cost starts becoming on par, or in the neighborhood, So that's what I think we have to achieve here, the institutions adopting robotics. So, questions, comments?
Normally what I do is I put in an ICD and all for 3 months so that there are no adhesions inside the cavity. Do you do anything like that?
There's different things, people do, some people don't do. What I do is we put a paediatric Foley catheter inside, keep it in, give some estrogens, so you know that they don't have some ashes.
Now supposedly the data would suggest if you have defect on only one wall of the uterus, adhesion should be very, very low. Supposedly. Hysteroscopic data would suggest that.
Hello, this is Abhinivesh Chatterjee, Columbia Asia, Kolkata. I just wanted to find out whether any difference in multi-layer suturing and single-layer suturing in myomectomy. Because there are a lot of studies published where single-layer has been compared to multi-layer. But mostly I've seen you are doing 2-layer suturing.
So I think we instinctively feel that a multi-layer closure is better. I don't know what's out there. So we always do a multi-layer closure. At least
if you are not using barb suture?
Yes. When we were not doing bar, we were doing vital, we were still doing a multi-layer closure.
But the studies suggest both are same
outcome. We had studies out for cesarean saying that single-layer closure was good enough, and now we're going back to saying, no, it's not good enough. We need to do a 2-layer closure. So we just take it and say, we think, and I think we intuitively feel that it's better to do a multi-layer closure, so at least 2 layers. Sometimes we end up doing 3, which is including the serosa, because the defect may be deep, it's an intramural going down and having a submucosal extension. So,
the data shows that until the recent era, uterine ruptures were very rare after myomectomy. Then they became a little more of a problem. And the study that Roopina showed from Dr. Parker, what was happening there was one of 2 things. Number one, technical shortcuts, 1 layer, or some of them, they would just close the serosa. Okay? Number 1. Number 2, burning the heck out of the myometrium. Okay? And if you do a good sort of tissue-sparing, tissue-respecting procedure and do nice multiple-layer closure so you don't get basic vacuoles of blood forming in the interstices of the myometrium, you should have excellent healing. And me personally, I'm much more aggressive than 97% in offering vaginal deliveries to our patients. I don't know what the data will show when we get to it, how many are delivered vaginally, but I personally delivered 2 or 3 vaginal deliveries. And a lot of the times I had to come in myself because my colleagues were afraid to do it. Okay?
Have you noticed any recurrence and again you have reoperated on those cases and what were the difficulties you faced?
I personally haven't had any of my patients come back. It's not that we haven't had, maybe they didn't come back to us. We are in the process of collecting our data now, our long term, and seeing. We haven't. Have you?
I've done a hysterectomy. I've done a myomectomy.
But if the patient needs again a myomectomy.
That's what I'm saying. I've had a hysterectomy after prior both robotic procedures. I've had a repeat myomectomy, and I have 1 more repeat myomectomy. That's 2.5 years out, and the myoma that's now causing a problem was this big.
Was that what you were asking, Arnie, if you would go for a little one?
Well, that and other reasons, but it was deeply embedded in the anterior wall. And actually, this patient, I'm operating on her next month. I even did a hysteroscopy on her. So I knew she had an intracavitary fiber. So I did the robotic, she healed, I went back and resected an intracavitary, and she's still, this is obviously a person who's going to grow fibroids, this is just, and she wants another myomectomy. So.
But we find that there are not many adhesions because some of our patients have undergone delivery and C-sections. And we've asked people who've done their cesareans, if we weren't there, how did the pelvis look? And they've told us they haven't seen adhesions. So that's just anecdotal.
Yeah, adhesions weren't bad. Some epiploica stuck to it or some momentum. There was some.
You showed us both the base wall sutures as well as the continuous sutures. Since this morning we have seen 2-3 times that and 2-3 times the other one. So what is the long-term effect of both the sutures? Is there any difference in the outcome? And the second question is, if you have multiple fibroids, do you go through the same incision or you have to put another incision for robotic surgery?
So for the first question, I know I don't know the answer to that because I don't think there are any studies that have done based on the study, the sheep model, which just came out of Brigham's that Dr. Enriquez was talking about. They compared the Vital with the barb, and when at AAGL somebody did ask Dr. Einerson that did he notice any difference if somebody did a baseball versus a continuous, and they said did not see any difference in adhesions because the idea of the baseball is so you have least amount of suture exposed outside to the serosa, so your adhesions may be lesser, but they did not see that. So people use different techniques. It takes a little longer time to do the baseball. As Arnie said, when his fellow suturing, they'll let them do the baseball. Or when the resident wants to practice and they feel happy, they have a longer time sitting on the robot and suturing. I do the baseball. I don't think there's any data on
multiple fibroids.
So you try and take them out through the same incision. If you think you can pull them out, you try pull them out from the same. But if you can't, then it's better to have a bigger, more generous incision instead of pulling it out because it's going to spend time and get frustrated, it won't come out. But we do not have a problem making more incisions if we have to. As you saw Dr. Pitters, you saw Dr. Winkler. You go where the fibroid is. Sometimes it's a family of fibroids. You start pulling and everything starts coming out from one incision. But
Is
if
it
it
a
doesn't,
routine to put the intercept for you? Are you
we put intercept routinely.
Routinely in all the cases.
Apart from vasopressin, how else do you reduce intraoperative blood loss?
So I had a patient who had a lot of hemorrhage despite her vasopressin. Some people use preoperative Lupron. I don't. I feel that my dissection planes aren't good enough, so I don't like to use Lupron prior to myomectomy, hysterectomy, yes. Second, so one is vasopressin. The other is you can use your mechanical tourniquet. You can do something around the uterine artery. People go up and get the uterine artery at its origin. We have laparoscopic bulldogs. So I've started using those for the IP. They're used by urologists when they do the nephrectomies for the renal arteries. So that's something which on a spring clip you can go and place it on the IP. You use it after half an hour. You just need a grasper to take it out. So you can put it like a laparoscopic instrument to place it.
Anything in your technique that can reduce the blood loss intraoperatively?
So some people are thinking if you give like a horizontal incision versus a vertical incision, there could be a difference in blood loss. Just be fast. I think the biggest thing is being fast enough and suturing.
Be in the right plane.
Right plane and suture and do it fast. And you don't want to be there.
So Dr. Payne, when you do all your cases, removal of the uterus vaginally, if it is a large one, if it is a very large uterus, broadly, transversely, enlarged, do you bisect by robotically above and then take it out?
I've tried it, I think, every possible way with an isolator.
Yeah.
And I've tried that.
Yeah.
It takes a long time to bisect using a monopolar device. Now they do have these called Lena loops, these things that you got. I've tried. I just take it out vaginally. The old-fashioned way.
I wanted to ask you.
Yeah, I've had very little problem doing that, so I don't deconstruct it. If I was going to do that, I'd probably use a morcellator. I do have a partner that uses a morcellator all the time. He just morcellates it into quadrants and then takes it out vaginally. You know, instead of morcellating the entire thing, he just does it where it's small enough to take out vaginally.
Because when we were doing vaginal hysterectomy, very large ones, we bisected from the
Right, you can do that. Whether you bisect, wedge, core, like I said, I just hack it out. I do whatever it gives me, I do.
But now that we are doing robotically from above, but we not use above, down.
Yeah, I don't do anything from above. Once I just get it disarticulated, I undock and take it out back. I think it's quicker than some combination of both.
The smoke issue is the big one.
Yeah. I mean,
And it's maybe our new system, so that if we can suck that smoke out and keep our pneumo, that'll work better. But that's actually what we'd like to do, but the smoke is annoying.
And I think people have to try different techniques, whatever works works for you, but you want to find out what's the most efficient way. You want to do a hysterectomy in half an hour, then you spend 2 hours trying to isolate it. Then again, you're setting yourself up for failure, you're frustrated. So you try something and then see what works and do it consistently, because you just want to be efficient in whatever you do. People do all different techniques. You do Schwarzeneggers, you do it gradually. David wants to try the renal loop, so it doesn't work. So
It works. I just
I used to try bivalve, use the cut on the monopolar, the scissors, and on the SI you can use a cut and try cutting it, but again, it takes a longer time. So after seeing a couple of videos at AAGL, I've started morcellating it to reduce the bulk and then pull it out gradually.
Before a laparoscopic myomectomy, we normally do a hysteroscopy to find out whether there is any submucous fibroid and resect it. Do you do the same thing before docking?
We don't
in robotic
we don't
myomectomy?
routinely do it because we order MRIs, and if there is submucosal extension and the fibroid is intramural, you can take that fibroid out robotically. We don't routinely do hysteroscopy at the time of
Yeah, we always do MRIs as well. It's really worth the time to do that, but you need to talk to the radiologist and tell them what you're after. They'll just order an MRI because they'll say multiple fibroids. Call them and say, I need the exact number of fibroids and pinpoint the location the best you can.
So we just say MRI for fibroid mapping, I just put down, and then I say size, number, location. So they want to give me these 3 parameters on there.
In India, MRI costs a lot. You can get the surgery done.
Well, you can do the same with an ultrasound if you have you have to communicate with the radiologist though.
Clearly,
Or you can use it
ultrasound is not as good. 3D ultrasound, if you have available, seems to be equivalent to what you get an MRI. What's beautiful about an MRI, especially if you have the luxury like we have at Ford of having it online in an electronic medical system that everybody has access to in the system, is to sit with the patient. Even the non-initiated can see what it is on an MRI image and scroll through and really explain to the patient. I find it to be very valuable, but it's costly for sure. And the third aspect is intraoperative ultrasound. The people who are making these new needles to sort of zap fibroids, is it called HALT is the name of the company, are showing that it's probably even better than MRI to have an intraoperative ultrasound pro, laparoscopic, like what we were showing. Now, that is the latest, that little submarine we float in the abdomen. But there are wands you can use, so you don't have to go to the latest generation to do that.
It's a question not directly for robotics, but since we're gynecologists here and everybody is talking about fibroids, I just want to know what is the status of MRI-guided HIFU for these fibroids in US?
It is not being done very often.
That's what
I had one patient that was really high-risk patient, and we really want to look into the possibilities. And it was so expensive, she decided not to have it that way. So it's extremely expensive.
Am I mistaken, or is it contraindicated like uterine organ embolization for pregnancy or subsequent pregnancy?
It is really contraindicated.
ACOG considers it experimental. But what I'll say also to that is that it's basically another format for in situ fibroid kill. It's essentially what it is. And we know that it's a nice alternative to surgery that's far less than definitive. It has problems. And as far as Michigan is concerned, Lakshmi, I don't know if you knew this, the closest... What's that? No, I'm talking about HIFU again, exibly. I don't know if you knew this, the closest platform that we have is Kalamazoo.
Kalamazoo, I know.
Right?
Actually, I
So
called Kalamazoo.
patients will ask me, and I'll bring up the website. Here's the hospital Kalamazoo. Give them a call if you want to go check it out.
Yeah,
But I think it obviously UFE is much more accessible, and I think it's probably something you should utilize as much as you can, because what you give vis-a-vis sending the radiologist, if you've got a good relationship, will come back to you.
And
That's what I think.
they also have to have an MRI before the UFE.
Yeah, what about robotic conversion? Suppose you have a bleed or you have some technical difficulty or a technological problem. So you convert them to laparoscopy or Roopina, how do you decide? And I mean, there are no studies which are talking about, robotic conversions.
There is
I showed
conversion to
you
laparoscopy.
in the table. They had pretty much zero conversion in the body plow like the exact
So anybody who starts doing robotic will have zero coordination?
Dr. Payne's data.
We had about
Okay.
We had, in our first 100 cases, we had 4 conversions, all done by my partner, by the way. I always like to give him credit for that. And in the second 100, we had none. This story is not unusual. I've done 3 abdominal hysterectomies in 6 years, 2 at a hospital because there was no robot, and the other one was a surprise sarcoma that we had to open because I didn't realize it was a sarcoma until we got in. That's it. I haven't done an abdominal hysterectomy since 2006, January, other than those 3.
I think what she's asking is, she's asking is off this platform too. If you convert, what are you converting to, a laparoscopy or an open case? And my answer is open because if you can do it robotically, you can do it laparoscopically.
There might be a scenario like an equipment breakdown, like one of the robotic arms broke down or something where you couldn't use a platform. I can't imagine any surgery that you could not do robotically that you could do laparoscopically. I think the opposite could be true,
But if you're going to open for bleeding or something happen, then you have to open. When it's an emergency, you're going to open the patient. But when we say convert, we're converting to open, not laparoscopy.
Yeah, my question is to Dr. Gavini. It's regarding the complication rate of open versus the robotic hysterectomies. Is it done by the consultants always? The open hysterectomies, they might be done by the junior residents, the senior residents or the junior doctors, whereas the robotics are always done by the consultants. That might be the cause of difference.
Not particularly. There's always an attending physician. We don't have independent, very rare the independent residents will be doing surgeries without the attending physician being present. And so that is not the issue. It is just the kind of case. I looked into the case of complication rate, why abdominal cases. They all had adhesions and significant adhesions. Would it be the same? And we had adhesions on the robotic side too. You can't always put exactly what is the cause of that particular adhesion that they had. The uterine problem. Dr. Payne was talking about, he had one case with the uterine injury and the abdominal case. I had one case not too long ago with the open case, mainly because it was very complex and we could really see that we are so close, but we couldn't stop oozing. So we had to put a clip and we knew we got the uterine. So sometimes it's just the kind of cases too that we had, I think. That's what I could come up with. But bleeding definitely is a lot higher in patients with open cases, and blood transfusion rates are much higher in open cases.
I think with that, we're going to break. I think we had more than a full day. I think we saw... One more question in the back.
You have given a very good tip that we should, Dr. Roopina, that we should pull the thread with the needle, because I remember breaking many suture materials. One more thing, can you give me a tip so that we don't char the tissue? I remember my first uterus being barbecued. So I see in your surgeries that they're really absolutely...
The other tip for the user is don't hold the needle control, because your needle is stretched down, it's going to fly in the abdomen. So hold the suture when you have to, or hold the tissue down. Second thing, are you using a PK when you say charring?
Charring. No, your surgeries are absolutely, Dr. Thomas Payne, I think. Your surgeries were absolutely without any charring. They were, so can you give us a...
Yeah, I mean, I think about every other sentence I said was equal and opposite tension. So you have to create an environment of constant tension on the tissue. Now when you go through major vessels, you want to slack off a little bit because you'll get in a little bit of bleeding if you do that. But otherwise, in between the major vessels, you want your assistant to pull the tissue one way, and you want either yourself or the assistant, you want to use the sidewall or the uterus to create tension. So when you're going through tissue, all you have to do is just touch it with the current and it just spreads apart. It just melts away. We call it painting. You paint the tissue. You just draw and paint instead of cut. You don't ever dig the scissor in. If you're doing that and it's not working, then you're not creating that equal and opposite tension throughout the whole case.
That's painting, P-A-Y-N.
Yeah.
One more thing you have to look at is what are your settings, and slower your procedure is, there's more charring. So you have to have that flow and the
But yeah, the more tension you use, the lower the setting you can use. Right? So we put our settings on 30, 35 max, usually 30, but we use a lot of tension, so it still just melts away.
Yeah, so go with the flow. Don't stay in one spot that causes a lot more time.
Thank you, everybody. Good night. We'll see you tomorrow. Have fun tonight.